Everybody sit in the back.
Good afternoon and welcome to our multimodality imaging conference. Today we're going to talk about stress echocardiography in the assessment of people with chest pain. And the outline will be a brief discussion on how we evaluate regional wall motion, and then the principles of stress echo, a little bit of how to, and multiple examples. And then we'll finish up with a couple of clinical scenarios where stress echo is still a very cost-effective technique, even in the presence of more sophisticated modalities such as PET and coronary CT angiography. So the principle of any stress test is that as the heart becomes ischemic, then several things happen. If the ischemia is due to an obstructed coronary artery that is affected with blood flow, then the first thing that you're going to see as stress proceeds is that there's going to be a heterogeneity of flow. The area that is supplied by that particular vessel is going to have less flow or flow reserve than the other areas. And this nowadays is what we detect using nuclear techniques like SPECT. Certainly with PET, we do it even more sophisticated, and you can do it also with CMR. Very soon, as this disparity in flow occurs, the cells become ischemic. And the moment the myocardial cells become ischemic, there is an element of dysfunction. And that's where the echo comes in, is to pick up that regional dysfunction, which you also could do using MRI or CMR. EKG changes are late. Often they don't happen. And of course, as we all know, angina is even more late and frequently doesn't even happen. In fact, one of the fascinating things about angina is that you have a patient with classic angina with stress. They get angina walking to their post office. And you put them on a treadmill and you do a stress test in a treadmill. The treadmill is very positive, stress echo, nuclear, EKG, whichever modality you're using, and the patient didn't get angina in the treadmill. And we still scratch our head figuring out why is that? Why is it that in a protected environment where you have nurses, doctors, and everything, the patient goes through the treadmill, they get short of breath, they have ischemic changes, but they don't get angina. And yet at home, they get angina with similar or even lesser amount of exercise. It's still one of those fascinating things that we have not completely explained in terms of what the mechanisms for angina are. So, the first thing we need to do before we put somebody on a treadmill or a bicycle is that we want to know how to assess regional wall motion. And basically, we look at 17 segments of the heart, and we assess their contraction in terms of, is it normal? Is it hypokinetic, thickening less than normal? Akinetic, where they're basically not thickening? Dyskinetic, when it's going the wrong way during systole, or frankly aneurysmal, which is of course a deformity that is seen not only in systole, but also in diastole. So in this example, we have this inferoposterior area that is clearly hypokinetic compared to others. In the 4-chamber view, everything looks pretty normal, but in the 2-chamber view, we have thin, bright, non-thickening at all segments of the inferior wall, which we would call akinetic. Remember that hypokinesis and akinesis don't always mean lack of viability, and that, of course, will be a subject for another lecture. But we clearly have seen with the use of CMR that segments that are hypo or even akinetic can still have viability. So this is the segmental division of the LV that has been done now for over 20 years, where we use 16 segments plus the tip of the apex as the 17th segment. And each segment has a coronary artery distribution, as seen here, and I think most of us are pretty familiar with that distribution. Just remember that in a 4-chamber view, the septum most of the time that we see is an inferior septum, so it is really this part of the septum here, which is supplied by the RCA, not the LAD. So to see more an LAD part of the septum, we need to be in either an apical long axis or a parasternal long axis, where we're sure that then these segments are LAD segments. Towards the apex, it doesn't matter where you are. The apical segments usually are LAD related. And also remember that there is some variation in terms of supply between the RCA and the circumflex. If you have a dominant circ, obviously you can have the same territories that you would have had with an RCA. So the system is very simple. We apply a numerical score to the segmental function and add it up, divide by 17. So a normal heart would have 1 times 17 divided by 17, and the wall motion score index would be 1. As you have more and more segments that are abnormal, this numerator increases and the whole score index will increase. And when you do stress echo, then you're going to be looking at changes from rest to stress. So we go back to this example that we started with, and now we put a numerical score to the hypokinetic and the akinetic segments and the normal segments, and we come out with 24/17, or a score index of 1.41 in this patient at rest. So with that intro, then we get into stress echo. And the concept of stress echo, of course, is that as you exercise the patient or do some stress to the heart that requires an increase in coronary reserve and blood flow, the heart should continue to function very well, and in fact, if anything, should function better. As we see here, that immediately after exercise, the ejection fraction has gone up, and every segment looks really good. In contrast to this example, where there is a left anterior descending obstructive lesion, and you see that these areas that appear fairly normal at rest become abnormal right after exercise. So that's the principle of a stress echo. You do the stress, you evaluate the patient clinically, blood pressure, heart rate response, symptom developments. You always look at the EKG, and then you have the echocardiogram to guide you as to the presence of a change in wall motion that would imply ischemia. So the reason we can do that is because during this ischemia, there is a transient, reversible, systolic, and even diastolic dysfunction. The good thing about it is that when you have ischemia, the dysfunction may last for a little bit, even after you restore blood flow, because of this phenomenon of stoning. And typically in a regular exercise echo, when you get to a point of peak exercise that the patient develops some ischemia and there is some wall motion abnormalities, even though the patient stops exercising, comes down and lays down, and you take a picture, in most cases, you have between 1.5 to 3 minutes of time where there is still this residual ischemia or stoning effect that allows you to get your images and assess the heart. Now, you don't know if in the particular patient you're doing it's going to be 90 seconds or 3 minutes. So therefore, one of the principles of stress echo when it's done on a treadmill is you really want to acquire your images, if possible, within 60 seconds, certainly not much more than 90, because the longer it takes for you to acquire, the chances that the wall motion may start restoring back to normal. And that's why stress echo as a technique for sonographer is a relatively intensive technique, and usually you don't start your beginner rookies doing treadmill stress echoes because it does take a little while to become an expert in doing this. So the views that are commonly used are parasternal long and short axis and the apical 4 and 2 chamber. In fact, if you cannot get good parasternal views, that's okay, because most of the time you will be able to look at every territory of the coronary arteries by doing 4-chamber, 2-chamber, and an apical long axis, which is the equivalent of a parasternal long axis. So you would lack a short axis, but you would be able to really evaluate pretty much all of the segments of the heart if you are unable to get a decent parasternal view in a patient. So here we have a positive patient, and in many of the examples that I'm going to show you, I'm going to continue to have these little practical tips here, because I think that this is the key for learning how to assess wall motion during stress. So here we have a heart that is normal. This was a patient that presented with 3 months of what sounded like fairly typical angina with effort. And at rest, we can see that in the parasternal view and short axis view, the heart contracts well, the ejection fraction appears normal, every segment is contracting well, and the same can be said for the 4-chamber and the 2-chamber view. Now notice that immediately after exercise, when the patient lay down, number one, the end systolic cavity looks bigger. Watch the size of this end systolic cavity now, 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 and watch it here, now, 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 and very evident in a short axis view. So there has been kind of a diffuse global increase in end systolic volume. Now it's not just the whole cavity, because this is obviously a very prominent case. I'm starting with a very easy case. But when you train your eye, not just only look at the whole cavity, also look for regional changes. Again, notice the end systolic diameter right here. Now, 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 and watch it here. Now, now. So there has been regional as well as global dilation at end systole. Always important to pick up a look at the EKG and make sure that you still have a nice, good, narrow QRS and you're not dealing with a PVC, which is sometimes, if somebody's having a lot of PVCs, the system can acquire a PVC beat, and obviously that would take you to a whole different ballgame in terms of your assessment. Now, come back here to 4-chamber and 2-chamber. Same thing. Notice the size of this end systolic cavity here, here, now, now, and see how much bigger it has become. So obviously, this is a very abnormal case. Ejection fraction has fallen with exercise, and there is global dilation, implying some sort of global ischemia, which could be a left main, it could be multivessel disease. This is another example, again, fairly positive, not as positive as the previous one. Here we're using contrast, but you can see, for example, in this 2-chamber view, this is rest. Notice with exercise, again, regional dilation at end systole, okay, very noticeable in the short axis view compared to the resting, and very noticeable in the parasternal view. However, look what's going on here. Can you all see a little this QRS? Can you all see it? I don't know if you can see it from the screen. But actually, right here, the system captured a PVC. So this particular beat, as abnormal as it looked, where you might think of a really bad thing, well, we have to probably throw it away, because unfortunately, it was captured right with the PVC. And those are some of the little things that sonographers, you need to pay attention to when you are doing your capturing, because you can quickly recapture if that one didn't work out. But excluding that particular bit, still with the short axis and the apical views, there is an abnormality of contraction here in an LAD distribution. So how do we stress the heart? Exercise is the preferred way, both with treadmill or bike. We can use dobutamine as a catecholamine inducer, and certainly there's been a lot of dobutamine stress echoes done over the years. And you can use atropine or hand grip when you're doing dobutamine to further increase the heart rate, increase the afterload, and try to enhance the sensitivity of the test, because in general, dobutamine tends to be less sensitive than exercise. Now, the post-treadmill, which is the one that we tend to do the most, has the biggest advantage that you're doing a conventional treadmill that we have done for years. Most people use the Bruce protocol. Everybody has a treadmill in their office. You are measuring the physical capacity of a patient. You're looking at the EKG for ST changes, their symptoms, their blood pressure response, and then on top of that, you have the wall motion. So it gives you a very complete test using a modality that has been very well used over the years and everybody is familiar with. The limitation is that of all the stress echo modalities, this one is the most intensive for a sonographer, because again, you have about 90 seconds to acquire your views. You're trying to acquire the same views you had at rest, which means you have to keep some sort of memory in your brain of how these views look like, so that when you go right after and start imaging, you're trying to reproduce very similar views to what you had done during resting. And of course, the resting images were done relaxed, without any pressure, so you usually got some nice images, and now you are working against time to get some decent images. So this is not where you start your rookie sonographer in the first day of class. This is something that requires sonographers that have gained some experience already with LV assessment, with regional wall motion. Usually it's better to start them first with either dobutamine or bike, which are a little bit more relaxed, and kind of move towards treadmill rather than throw them in the treadmill lab on the first day, because it is more intensive, no question about it. And even with the best techniques, at times we end up with a post-exercise image that is not exactly the same as the resting one. And then we have to decide how to manage that when we are evaluating the patient. Important, of course, like any type of stress technique in the treadmill, the best accuracy is when a patient reaches 85% of the maximal predicted heart rate during the exercise. The heart rate at the time of capturing the views is of no importance. I've seen some of the fellows make a comment about not able to reach because the heart rate at the time of imaging was, let's say, 85 or 90 or 100. It's the heart rate the patient reached during the treadmill. Once the patient stops and lay down, many patients will slow down nicely, and you capture at a heart rate of 100 or 90, and you have some, if it's positive, you can see some nice positive changes. That heart rate is of no importance. It's what they reached when they were exercising. Okay, so that's a very important point to remember. Okay, this is for mostly historical interest. This was the very first study. Many of you were not born. This was 1983. Dr. Limacher is now retired. And this was the very first study that put this technique in the map with 73 patients that they all had coronary angiography. And there was overall sensitivity of 91%, specificity of 88% with the test. And these were obviously well-selected patients. They all had symptoms requiring, they were already going to go to the cath lab. So obviously, this is not necessarily your general public type of data, but it was very important because it was a study that was fairly well done and put the technique in the map. Close to 10 years later, though, when we were now doing this in a more routine basis, we did this other study that was very important where something like 289 patients underwent simultaneous thallium and stress echo. So the same treadmill, but on the same treadmill, they got injected for the nuclear and they did the ultrasound. And we ended up with an 88% agreement between the two techniques. And importantly, most of the disagreements were the type where the technique was picking something that the other one missed, because we had coronary angiography in the majority of patients. So actually, there was, in this particular study, no real preference of one over the other. And these were the findings in terms of coronary angiography. When one vessel disease with 70% or more, both had some very, very nice sensitivities. And then 2 and 3 vessels, of course, very high too. Specificity appeared to be a little bit higher for echo than nuclear, but again, not statistically significant. In 1990, this was one of the first meta-analyses that came out. Now we're talking more than 3,000 patients. And again, both techniques fare very well in sensitivity and specificity. Specificity of SPECT was less. In this particular analysis, it was significant because of the sample size. And I think over the years, I'm not sure that this is totally correct. Unfortunately, both SPECT and stress echo, when they're taken out of laboratories with a lot of expertise and then go into what we call the street. In other words, they go into the offices of doctors in practice, I would say both have their share of specificity issues. We have seen many stress echoes from the outside that were red positive, and we look at them and they clearly were not. And of course, the same thing happens with SPECT. So I think, again, this, because it is a technique that is manual, that requires expertise of people, all of these statistics start falling down as it's performed by people that don't have the same level of expertise. That's why it's so important for you guys to really learn it well, so that when you go in practice, you can do it with the same level of accuracy that we do it here. That same group of patients were then followed for 5 years, and another study was then reported comparing the ability to predict outcome for both techniques, and both fared very, very well. And then this study was put in together with the same group of patients. My goodness, Bill, where is Dr. Mansour these days? You know, have you kept up with him?
Cincinnati, probably.
Yeah. This was a study that Dr. Sogby actually led, and it was basically just showing that the beauty of the treadmill is that you also have the rest of the treadmill. So not only do you have your wall motion, but you have the duration of time in the treadmill and the EKG changes. So a risk index was put together, combining then the entire level of information that one gets from a treadmill stress test, and showed very nicely that the higher that index, the higher the event rates in patients when they were followed over about 5 years. Now, bicycle is a very, very nice technique. And you need to have a special bicycle that allows you to bring the table slightly lateral so you can get the best quality of images. And then you do a resting and during exercise. And this is a real advantage, because now you can go low level, medium level, peak level, and see what happens to the ventricle as you're proceeding. This is a nice example of somebody that starts in a 4-chamber view, nice and normal. 25 watts, continues to look nice and normal. Same thing for 50 watts. But at peak, see what happens. Again, here are our tips, okay? End-systolic cavity should be smaller at peak or post, not only global, but importantly regional. And when you're doing a bicycle, the thing to do is to compare with lower levels of exercise, because with the lower levels of stress, for example, right here, there was a slight improvement in function in this lower level. And now when you look here, notice that right here, the end systolic diameter now has dilated compared to here. Now. So there is end systolic dilation, particularly at the base of the heart, much less towards the apex. So at the apex, it doesn't look that bad. Now compared to now. Okay? So what's going on here? Well, which territory is this? IOM. Yeah, it's a circ. OM, yeah, exactly. So this is a nice example of ischemia due to a circumflex lesion that was picked up nicely with a bicycle stress. And in this, when you use this modality, it's better not to do a peak to rest, but a peak to lower levels, because you can even emphasize more the changes as you do the comparison. And in fact, in this study that was done by Dr. Badruddin, which I believe is in Corpus Christi, yep. It was done with a good sample size, close to 100 patients. And basically, first thing that was shown was that with a treadmill, you get a much higher heart rate response than with a bike. We've known that for a long time. But the bike gives you a much higher systolic blood pressure than the treadmill. And therefore, the double products are very similar. That's why, again, when we do supine bike exercise, don't pay attention to the heart rate. Don't make that comment that the heart rate didn't reach 85%, because you know what? In 95% of people, it won't reach 95%. Pay attention to the double product. It needs to reach 2200 or more. So with the bike, it's the double product that we pay attention to. With the regular treadmill, it's the heart rate that we pay attention to. 22,000, yeah, 22K. I'm sorry. Yeah, 22K. Okay, so, but however, this was a group of patients that every patient had a treadmill, next day the bike, and then they had coronary angio. So the statistics were very similar, basically. Bottom line is that they had both very similar. The specificity was a little bit better for the treadmill. This was not statistically significant because of the sample size. So it's a very, very nice substitute for the treadmill, and it has some advantage. This is a lot easier for the sonographer. If you miss the peak, if you could not get a good imaging peak, guess what? The moment the patient stops in the bike, they are supine. You don't have to do anything. They're there. So now you convert it into a post, and you do immediate post exercise, except that instead of being 90 seconds, you probably will get everything done in 60. Because the moment that patient stops, they're there, you have the transducer in the right place, and you can optimize your imaging. So you can very easily change the peak exercise to a quick, rapidly post, and still get a very good test. It's much easier in elderly people who are kind of scared of the treadmill, and they can do a nice bike. And then it's very good for patients where you want to also use Doppler techniques to look at mitral valve gradients in mitral stenosis, look at diastology for feeling pressures, pulmonary pressures, and things like that. So this is a patient with chest pain. So what do you all think? Is this a normal stress test? We're doing 4-chamber and 2-chamber. So we have pretty much the four territories, but the LAD is going to be here because this part here is part inferior wall. So I owe you the parasternal views. Anyone? Does it look normal? I mean, it doesn't look too bad, right? Yeah, so you have this here, okay, but notice when this happens, look at the mitral valve. Now. So this is actually an early diastolic event. This is not a systolic event. So in systole, this contracts well, but then in very early diastole, this area relaxes ahead of the others. It's an incoordinate relaxation, which you see once in a while. An important thing to do is when you see that, is to play this in a slower mode, and you will appreciate now that it's happening right at the time of mitral valve opening. So it's an early diastolic event, which is not necessarily ischemic. However, look at the segment here, and the inferior base of all these segments is the most tricky because there is some heterogeneity of contraction in all these segments, and the inferior base is a segment that appears always to thicken a little less and move a little less in normal people. So it becomes more tricky with the stress echo. And a lot of false positives actually happen to be in that area where people don't, get confused, not sure, and they call it abnormal. But notice that right here, this is thickening throughout systole. Now. And then I don't know if I can try to stop it and see. There. This is your end systolic diameter here. Now, watch this here. This is thickening. This is also thickening. But when is it thickening? Now. What else do you see when I'm saying now? Mitral valve. Mitral valve is opening. Okay? Now let me see if I can do this here. I don't think I can stop it. So this is a very nice example that we see once in a while of what is called post-systolic thickening. So it's early diastole where you see the thickening, and that is almost always ischemic. So actually, this was a patient that had a nice a single RCA lesion that was picked up nicely with the stress echo, and the tip-off is that the thickening was occurring in diastole. Now. All right. So let's talk a little bit about dobutamine. Dobutamine certainly is a modality that can be used and is used. We still do a lot of dobutamine stress echoes in transplant patients. There are two ways of capturing for the purposes of having a quad screen. One is to do rest, 10 milligrams, the peak dose, and then a post. And the other one is to go rest 5, 10, or 20, and then peak. There's no necessarily advantage of one or the other. It's more of a preference. Some people like to have a post image right here so they can compare with the others. And some people like to just have a gradation of increased contractility with the lower dose and then have the higher dose. Just as with the bicycle, you compare your peak with some of the lower doses, not necessarily the resting. Because if something is abnormal, you see it very nicely. Okay? Again, evaluate end-systolic cavity size, compare images peaked with low stress, look for distortion of geometry if there is any. Okay? This is just normal to show that. In contrast, what do you think is happening here? So here we have 4-chamber views, 2-chamber views. Again, look at end-systolic cavity, including end-systolic regional size, and then compare with this peak stress. And compare this peak stress with a lower dose where you have even more accentuation of function. Anybody sees anything? Look right here. Now. There. Okay. Here you have, I think I was lucky. Got it. Here you have this end-systolic diameter right here. Okay. Versus right here. In addition, remember, there's also geometry, distortion of geometry. This is the geometry here, where here, look at the geometry. Right there. So this is similar to the bike I showed you earlier. This is another OM. But wasn't it nicer to pick it up with the bike? Yeah, because the heart was bigger. It was easy to see that. Here you are looking at a tiny little heart with dobutamine and trying to scratch your head and say, oh yeah, it's abnormal. And so now you have not only the expertise of the sonographer, but the expertise of the interpreter looking at this. So, but once you pick on it, you can very nicely see it. I mean, there is an abnormality here with a distortion of geometry and a little bit of regional dilation, but the whole heart is smaller and you have to work harder at this. Where with the bike, it was there. I mean, it was very evident. Many of you immediately saw it. And that's one of the issues with dobutamine. It's a small cavity size, makes it a little bit more difficult sometimes to detect abnormalities. Absolutely. Yes, that papillary muscle make it look like the heart is doing great. Exactly. If you don't look at this area here. Exactly. You're correct. And of course, those are some of the good and the bad of contrast, because clearly contrast has been very nice, but accentuates sometimes these papillary muscles, and you have to keep be careful with it. All right. This one I think everybody picks up. If some of you don't pick it up, you're excused. You can go back to your afternoon duties. Yeah, this is your classic, right? This is your very nice, easy level 1 for any fellow. You see nice cavity here. Look at the low dose of dobutamine. Okay, now you see how nice and small this area here is. Now see how dilated this area is. And you see it in the 4-chamber, and you see it on the 2-chamber. So again, this is the one that anybody would pick up. What about this one? Again, a small heart. What do you think? Again, compare this peak with this one here. Make sure that we have QRSs that are equal, that there is no VTAC or PVCs. And compare this one here with this one here. What do you think? Anyone? The end systolic cavity is larger. Yeah, right. Is it regional or global? Yeah, when you look here, it looks like the whole end systolic volume has kind of gone up. Now, compared to there, look at that. And this one here too. So again, this comparison is a lot more easier to recognize than this comparison, because this might start looking more like resting. This is clearly becoming accentuated, and then here you have dilation of the LV, regional but global, because the entire area, if you trace this end systolic area, it's going to be clearly bigger than that. And then short axis. Now, versus here. So this is an abnormal dobutamine stress echo. But what is it due to? We'll talk about that in a second. All right. So the advantage of dobutamine is you get multiple imaging stages: rest, during, peak, post. You might be able to even time the origin of ischemia. In some people who have very severe lesions, you might pick them up at a 20 mics instead of having to go to 40. It's the level 1 for sonographer, because patient is resting, you're infusing the medication, everything is quiet and calm, and you can acquire your images. Still to this day, it's probably the best technique, if you're going to do a stress echo, is the best technique for patients with a bad EF. Because in bad EF situations, what you're looking for is coronary reserve, viability, and that's a subject for a whole different talk. But in that setting, you have already usually dilated hearts, and then dobutamine is a very nice way of seeing how the heart improves with low doses, if it worsens with high doses, where with exercise, the heart may go down very quickly because of the dysfunction, because of the cardiomyopathy existing in the patient, and it may be a little more difficult to look for viability. So it still is, of all the modalities of stress echo, the best one for patients that do have low EF, and your question may be a little different. It's not just what's causing chest pain. The limitation is that because the heart is so small, it may be less sensitive. And also, you're dealing with the heart rate, and not everybody reaches 85%, so you have to give atropine to try to make it go to that level, and so on. You have a higher incidence of arrhythmias. Atrial fib is about 1%. You know nothing about exercise capacity, and the EKG is worthless. Very rarely do you see ST changes with dobutamine. It's very interesting. Even when you have very positive dobutamines, for some reason, the EKG just doesn't show it. Okay, so as we have been talking about this, I think you can clearly summarize this yourself, right? What do we see with ischemia? Well, we see global or regional end systolic enlargement, wall motion abnormalities, geometric distortion. All of these two go together. And often you see an EF that is either flat or actually drops, which is more specific. A flat EF is less specific for ischemia, particularly in women. It's been shown that when women exercise, they might have an EF that is in the 63%, that stays in the 64% with exercise. They don't have always that dramatic hyperdynamic effect. So flat EF can give you perhaps more sensitivity, but it costs you at a specificity point. So if you drop the EF, that's quite specific. Now, what happens when we drop the EF diffusely and we don't have a regional change? Well, you are dealing with either very bad CAD or you are dealing with some form of cardiomyopathy. I mean, that is the two things that are more likely. Now, sometimes you can have a very severe increasing afterload that can, for example, you're doing a dobutamine, the heart rate is now 150, and the blood pressure shoots to 220, 230. And that combination of a fast heart rate and a very high afterload suddenly happening could make a global reduction in function. We've seen that once in a while, and the patient gets cath and the coronaries are okay. So this is an example of that. I hope you all can see this was exercise echo, right? Plain exercise. And you can see that there is a global drop in EF compared to rest. The rest EF was not great to start with. Very nice images with contrast. A little bit of problems here with they should have waited just a little bit longer. But overall, it's a good study. And we can see in the short axis view particularly how the end-systolic cavity increased, the ejection fraction dropped. So this is a global response. Patient only did 3 minutes of exercise, became dyspneic. And what this patient was a patient that had a chemotherapy cardiomyopathy. Actually had a coronary CTA that was perfectly normal. And she had a large B-cell lymphoma, had received adriamycin and so on. So this was just somebody with a cardiomyopathy. Obviously, the exercise even accentuated more the cardiomyopathic response, but it was not due to left main or multivessel disease. It's still abnormal, though. It's still giving you information that may be important from the point of view of how you treat the patient, prognosis, and so on, but it's not necessarily obstructive disease. You've seen a lot of contrast, so I'm going to go through this very fast. But this is the study that put contrast in the map. Dr. Sogby led that with Dr. Plana, I believe. Yep. And you've seen this example. You have seen this example already. I showed you this earlier when I was joking that this is a level 1 for the fellows to make a diagnosis of LAD. However, without contrast, I don't think it would have been. See, without contrast, you would scratch your head. And you start saying, gee, I'm not sure, maybe here, this area might not be as good as here. You put the contrast, and it was like turning the lights on. And this was a study that was done with dobutamine. Patients were studied without contrast and then repeated with contrast. And it was a very important study because it showed not only that contrast can be great for a case like this one, but also that contrast is not always needed. And in fact, what was shown was that if you have all segments visualized nicely without contrast, you gain nothing by giving contrast in terms of improving the accuracy when against coronary angiography. Even if only 1 or 2 segments were not very well seen, the gain was non-significant. It was when more than 2 segments could not be seen well that you had a significant gain in accuracy. And that's why, based on this study, official recommendations later had been to apply contrast to stress echo when you have addressed more than 2 segments that you don't see well. What about strain imaging? Well, we know that strain imaging at rest can give us, on the bull side, abnormalities that follow the regional of a coronary vessel. So if you have an ekinetic apex and because of an LAD, you're going to see a very abnormal bullseye in that region. If you have an inferior wall, you'll see it here, or a circ. So we know this from resting studies. So it makes sense that if you become ischemic and you do a rest versus stress, that you'll see a change that would indicate ischemia in a particular vessel. And this would be, for example, an LAD at peak stress. Problem is that it's virtually impossible to try to get decent strain post-treadmill or even with a bike. So pretty much the whole literature that has been reported for strain with stress echo has been with dobutamine. And this was in 2019, and there may be some newer ones, but by then already they had close to 1,000 patients from a meta-analysis, and 10 of these 13 studies had coronary angiography. And again, they showed us that when done well, strain could be quite accurate in picking up abnormalities that indicated a lesion in a particular territory that was corroborated by angiography. That was the good news. Problem is, again, only with dobutamine, and you need to have very good quality image. And as we showed earlier, particularly in good old Houston, Texas, we use contrast a lot. And once you put contrast, it's very hard to do proper strain. So for all those reasons, it really have not reached prime time. It's not something that most people do on a routine basis, including ourselves. So some facts about stress echo. First of all, exercise echo is an accurate test for detection of ischemia and CAD, very well shown. Its accuracy depends on expertise, both of sonographers and the echocardiographers. Accuracy is limited in patients with left bundle, just as it is with nuclear. Probably left bundle branch patients right now, the best way to work them out is either go straight to CTA or a PET, because nuclear suffers the same problem of having false positive. The problem is not specificity, because with the synchrony that you get with the left bundle, you can induce all kinds of funny wall motions with stress that appears to be positive. So it's not a good test for people with left bundle. The vitamin echo in general tends to be a little less sensitive than exercise because of the issues of a small cavity that you have to work through to evaluate. So if a patient cannot exercise, I mean, you still can use the vitamin. Personally, as a clinician, I prefer to use some of the other techniques, either SPECT or PET, or go straight to CTA. Again, with the exception being patients with depressed EF, because now your question is not necessarily the chest pain question, but issues with viability, and the vitamin still can be a very viable technique for that. So whenever possible, go with exercise, either treadmill or bike. Bike is preferred when there is a resting wall motion abnormality, because you have more time to assess that throughout exercise and see if it gets better, if it gets worse. And also, you can evaluate other hemodynamics like Doppler, PA pressures, and so on. And the butamine is preferred for viability. So let's finish up with a couple of the very simple scenarios, because why are we doing this lecture? Well, because we see patients with chest pain, right, in the office. In fact, I think in every single one of my clinics, I have at least one person that comes in with chest pain. So the advantage of stress echo is low cost, no radiation, results are quickly available. I mean, you finish the stress test, you can quickly look at it and make a decision. You don't have to wait for big time type of processing and so on. So let me give you two scenarios that are very common in our practice. The patient that comes in with chest pain and intermediate or higher risk factors that smells like possible angina. So you're really now concerned this patient may really have angina, okay? And there are two ways of managing this patient. One is to go with the anatomic evaluation, where you go straight to a coronary CTA. And there are a lot of papers being published now about this. If it's normal, you're done, right? Now, you still may have concern with issues with microvascular that we have not touched in this lecture. That's a whole different area, deserving perhaps a talk by itself. Clearly, PET is becoming more and more valuable. But at least in terms of obstructive coronary disease, you're done. Right? But if it's abnormal, the question is that abnormality causing ischemia? And you guys who are in the CT angio lab know this very well. You either try to do a coronary reserve that is not perfect, or that patient then has to go and have some sort of stress test after the CTA, which we also do not uncommonly. And then if it's positive, then you deal with it as any other patient that you would deal with. Selectively, you may use angiography, you may put a stent, you may do bypass, you may treat medically. That's all a whole clinical decision that depends on many factors. If it's negative, then the patient has obstructive disease, they have no ischemia, and obviously you're going to do aggressive prevention, but not necessarily have to go beyond. So that is the anatomic track, and there's nothing wrong with it. It's actually published and being used by many people. Personally, I kind of still like the functional track, where try to go first for do I see ischemia or not. A couple of exceptions. One of them is left bundles. I often just go straight to a CTA if I have somebody with chest pain on a left bundle, just because I know that the specs and you know, PET is not always easy to get from an insurance point of view. You have to go through a few tricks to get it. So not uncommonly, I will ask for a CTA in that situation. But in the regular kind of patient without left bundles, I still like the functional test. And if the patient, you know, is in a fairly good health and they can exercise, stress echo is still very cost effective. You get good data, good information, you can make decisions on how to treat the patient. Nothing wrong with doing a pharmacology spec or exercise spec or PET, but these are more expensive, more involved, they have some radiation involved, and this is straightforward and you get your answer. So I like that. I like that approach. If it's positive, then you proceed as you need to. If it's negative, and in a patient that has important risk factors, personally, then I do a coronary calcium and use it for prevention, as we have heard many times from our esteemed Dr. Nasir, I'm sorry. Now, we also see a lot of these people, a lot of them, atypical chest pain. In fact, we see more of this than we see the real angina. In this patient, to be honest, personally, I go straight to calcium score because many of them are normal, and if it's normal, you're done. $140, even cheaper than the copay of a nuclear or echo or whatever. So that's my preference. You don't have to follow my preference, but I use this a lot because these are people that have funky chest pain. They're atypical, but if you tell them you're fine, go home, they don't feel, they feel like, you didn't do anything for them. In addition, there are people who have, many of them, risk factors of some kind, and therefore it's important to know, do they have any lesions. If they have a positive score and chest pain, then I do move to some sort of looking for ischemia, and again, stress echo. If they are healthy and capable of exercising, it's a very good modality. So it's the same story. This is a very cost-effective technique. If they cannot exercise, that's a different story. Obese, elderly, then now you're dealing with a decision, do I put them in a bicycle or do I go the pharmacologic way? And of course, or do I do butamine? Personally, I tend to go in this direction most of the time if it's somebody obese, sedentary, that cannot give us a decent exercise. And of course, everything I've said has been very well documented, and this document that was published in 2008 hasn't changed in terms of appropriateness. All of these scenarios that I just discussed are scenarios where stress echo is a very appropriate test. And again, the biggest advantage is cost effectiveness, no radiation, and you get your data relatively quickly. As soon as it's done and it's captured, you can go into the system and look at them yourself. You don't have to wait for a lot of processing. So thank you very much. We have a few minutes for questions. I'm sorry, Dr. Shah, I did not mention CMR. Personally, I'll tell you my bias. I do use CMR, but it's when I'm using CMR for a particular disease entity that I value a lot, the value of CMR, and then added to that the flow assessment. But personally, I don't use it as a first line for a chest pain evaluation.
Yeah, so the question I was going to ask you about the algorithm that you have for your atypical or low intermediate risk chest pain. Now, I think that's actually very interesting because I think a lot of people have toyed around with this algorithm based on some of the data from here as well that says if you have 0 calcium score. But I think most have been hesitant to pull the trigger to actually execute on that. So I congratulate you for that. And
yeah, as I say, this is what I do. You don't have to do what I do, but this I do. I believe all the data that he's shown. The data is very powerful. I mean, again, and these are usually between 45 and 60-year-olds. They are otherwise in pretty good health, and they come in with this very flunky chest pain. To be honest, many times you could just send them home with nothing. The problem is that you send them home with nothing. They don't feel too good about it. They think that, well, you really know. Second, they still could have disease because they're still human beings that have cholesterol that are borderline and this and that. So I think the calcium score approach to me is very valuable, very valuable. Any comments from Dr. Nasir about that?
I was going to ask you about how would you approach, and you kind of gave your wise thoughts on the best approach. If you look at the sensitivity and specificity of exercise and stress echo of 88 to 92 with the calcium score ruling out, it's almost 99%. So I congratulate you for leading the charge. The question really is, as a group, how we can put together an RCT really to lead the way as our group has done in the past for all the other modalities.
I think that's a great question. I think we have everything here to do that. Yeah, to put together some sort of a prospective approach, and yeah, we do. I mean, every expertise that we need, we have here.
I mean,
personally, for the intermittent chest pain, that they come to the clinic without chest pain. I don't use calcium score as a screener to say, yay, nay, do you have disease? I always use calcium score for risk stratification in the long term. Because the younger the patient is, the higher likelihood of a calcium score of 0, and may not tell you necessarily about the whole situation. I still use in my practice CT for excluding or ruling out as opposed to ruling in, mostly because of the ruling in and the high probability of disease. I'd like to know necessarily the extent of ischemia. And to me, functional testing nowadays, even if you miss a very tiny area of the myocardium with either nuclear or echo, all the data tells you if you have minimal ischemia, you do well, right?
So
with medical therapy or almost no therapy at times.
So I don't disagree too much with you, because the younger people is different. And of course, the calcium score, I always choose people that are already in an age where you expect it to. But luckily, I don't see that many young people with chest pain. But if a 25, 32-year-old comes in with chest pain, first of all, if the chest pain is I frequently use a stress echo, to be honest, just for reassurance. I mean, the probabilities of abnormality are very low, but they do feel a lot better when you tell them, you went fine, you did great, and everything is normal. I don't use calcium scoring at that level because there's too much of a false negative, at least for now, until Dr. Nasser convinced me otherwise. But the question is, I think that we could very well. We see a lot of these patients. We have all the armamentariums. We could sit down one day and think about how we could approach this in a way that might be of some value to the rest of the community.
The cost effectiveness really has not been, at least in this country, has not been pushed.
Yeah.
Because of availability of insurance and other ways to pay, although ultimately the patient will have to pay a chunk of it. But just imagine how often do you order a resting echocardiogram with an exercise nuclear stress test or a pharmacological stress test.
Yeah.
Just imagine,
Yep.
okay? So if you combine this situation in one setting, the saving is phenomenal.
Yeah, absolutely. Yeah. All right, guys. Thank you for coming.